talked about actually the behavior. That, it is the behavior of the tumor, mostly that is going really to tell you, which way the tumor will go. All right, so, now, going back to the tumors, it has two components. There is what you call the supporting components, or the holding component, the carrying component, and then there is the true neoplastic component itself. The true neoplastic component actually is the parenchyma. This is actually where the epithelium is dividing, if you will, giving rise to this tumor mass. Okay, so it is actually the parenchymal behavior that is going to determine the behavior of the tumor, because it is the truly neoplastic part or component. Now the stroma is, on the other hand, is actually what you call is there to support, to hold that tumor, if you will. Now, during the history of neoplasia, it has been shown that there is actually connections between the parenchyma and the stroma. What you guys are going to be reading about in the form of crosstalk. So the parenchyma and the stroma crosstalk to each other. There is an intricate relationship between the two of them that is going to guide actually these tumor cells in its journey to become invasive and metastatic. We will see that as we go through this series. So here is actually an example of the two components that are present in one. So the truly neoplastic component are these nest of cells, as you can see here. These nest of cells have keratin in the middle. So this is actually a keratinizing tumor. If you look at these cells, they are squamous cells. So it is keratinizing squamous cell. The tumor itself is keratinizing squamous cell carcinoma. All right, so these are the truly neoplastic component of this tumor right here. On the other hand, there is also what you find outside those nests is the stroma. The stroma is simply a mix of connective tissue, of inflammatory cells that are there. For a long time, we thought it is there actually carrying the tumor. We know now that it does actually play a very important role in the survivability of the tumor, in the tumor, making it actually to become a truly neoplastic and a truly invasive and metastatic tumor. So there is what you call, again, the crosstalk between the stroma and that actually of the parenchyma. Crosstalk between the two components of the tumor. The truly neoplastic part, it's the nest, and then there is also the the supporting tissue, which is the stroma. All right, so in terms of division, you divide neoplasm along two lines, the epithelial division, and then there is the mesenchymal division or mesenchymal tissue. Those that arise actually from epithelial tissue is what you call, the adenoma, for example, or if it is malignant, you call it the adenocarcinoma. So it may actually go benign versus malignant. The same thing exactly with regard to mesenchymal tissue. You see that it could be also benign versus malignant, fibroma versus fibrosarcoma. So again, why do you need this division? Because we will see that a lot actually about the behavior of the tumor is going to depend on what is the tumor. Is it an epithelial tumor or is it a mesenchymal tissue tumor? How is that? For example, we know that epithelial tumors are more likely actually to choose the lymphatic way to metastasize, to go with the flow and go to distant sites. Whereas we know that mesenchymal tissue tumors, usually opt for the bloodborne, the hematogenous route. As a result of that, mesenchymal tissue actually are going to give rise to metastasis faster than epithelial tissue. And we will see why that also as we go through this series. All right, so now nomenclature. How do you name those tumors? Starting with a benign tumor, of course, there is not really like a fixed rule that you will apply in all circumstances, but there is what you call most common. So benign tumors, you add an oma to anything, it's going to result in the definition of a benign tumor. Example of that, fibroblast. If you add to it fibroma, all right, fibroma, and that's going to be a benign mesenchymal tumor. You have a problem?
No, Doctor, just to use the laser function.
Oh. Thank you very much. All right, so fat cells, if you want to talk about actually if there is a proliferation of fat cells, a benign proliferation of fat cells that is giving rise to a mass, a benign mass coming out or arising from a fat cell, that's what you call a lipoma. Smooth muscle, you're going to be calling it Lyomyoma. If it's a bone, you're going to go to the Latin word for bone, osteoma. For a cartilage, again, you would go back to the Latin word of the cartilage, chondroma. So anything that you add a suffix after it will give rise to a tumor, a benign tumor in this case. Now, that's not all the case. That's not all the time. Why? Because we will see that there are instances where adding oma to a word is not going to result in a tumor, but rather it's going to result in a tumor-like condition, or even to a malignant tumor, as we will see. Now, for example, look at this lipoma. So this lipoma is a proliferation of fat cells. Benign proliferation of fat cells. How would you know that it is benign? If you look at this, and this is again going to be repeated again and again until it becomes a song in your mind. If you look at this tumor, the tumor is small. That's an important actually feature of benign tumors. 2, the tumor is not really invading through the capsule that is surrounding it. Another important feature of benign tumor. 3, the tumor, if you can tell even from looking at it, is freely movable, meaning it did not really invade nearby tissue and then become fixed to nearby tissue. So, and then you look at this tumor and you will see that this tumor does not have any hemorrhage or necrosis. All of those are features of benign tumors. Now, if you take a section of this tumor, you look microscopically, you will see this proliferation of very benign, very bland, fat cells. It's not really anything that, raise an eyebrow. All right, so here's another example of a benign tumor. In this case, a tumor that is arising from smooth muscle. In this case, what you call Lyomyoma. Again, even though there are a lot of them, and some of them are large, but if you look at this tumor, no hemorrhage in these tumors. The tumors are surrounded by a very fine capsule. So meaning that when the tumor grows, it does not really grow by invasion, it grows by pushing, what's called expansile kind of growth pattern, which is what you see with benign tumors. And you look again, is there any hemorrhage or necrosis? There are not. Is it movable? Absolutely. Even though it may actually be arising within the, below the serosa, subserosal. This is a Lyomyoma, subserosal Lyomyoma. Some of it are arising within the myometrium itself. Some of them are arising within, the endometrial cavity below the endometrial, what you call subendometrial. But you look at each one of those and you will see that the capsule is smooth and the tumor is movable. So all of these are signs, of actually benign tumors. You take a section of any of those tumors and you will see this spindly kind of, streaming appearance of those muscle cells. All of those actually are going to point you to, so it does look, streaming, but if you look at each one of those, nuclei, you will see that it does actually take the shape of a cigar-shaped nuclei, which is what you see with smooth muscle. So, and all of those nuclei look like each other. All of those nuclei are a small size, and there is a lot of cytoplasm. So the NC ratio is very low. So the cells that you're looking at are what you call bland cells or benign, benign cells. Not normal, they are neoplastic because they have given rise to a benign tumor, but they are benign, they are not malignant. All right. So how do you name benign epithelial tumors? Now here you're dealing with actually a glandular kind of actually, growth. And again, if you add, the word adenoma to it, you're going to come up with, the name of that, tumor. So let's say that a tumor is arising from a thyroid gland. That's what you're going to be calling it, thyroid adenoma. salivary gland, adenoma, and so on and so forth. If the tumor is cystic, you will add, this is actually one of the things that they teach, budding pathologists and pathologists in training, pathology residents in training. Then they will teach them how to name a tumor. So for example, if the tumor have a cavity within it and it's a benign tumor, then you have to add the word cyst because it is cystic. So this actually, let's say thyroid, becomes thyroid cyst adenoma, and so on and so forth. Again, to reflect actually, because when you hear it, you will be able to imagine actually what kind of tumor you're dealing with, okay? Here's an example of an adenoma that is arising in the endometrium. Now, whatever you see actually here, you're going to be finding that the glands are actually back to back. This is always a worrisome sign, okay? Meaning there could be actually malignant cells lurking, between those glands. But if you look at the overall architecture, you will see that there is no reaction from the stroma. Usually the stroma, when a tumor invades, this is a tumor that becomes malignant. When it invades actually nearby stroma, the stroma is going to react actually to this invasive cell, and it will react in the form of fibrosis. You look here and there is no fibrosis, meaning all these glands are actually, pretty much benign, really. But you have to go on higher power and you have to, decipher each one of those glands to make sure that what you are dealing with is a benign gland rather than a malignant gland. How would you tell that? For example, one of the things that you need to look at is the fact that these glands should have an outer lining that is covering the epithelium, meaning it will have a double layer. And that's an important actually finding in a lot of benign tumors. For example, if you're looking in the prostate and you're looking at a few glands in the prostate, one of the features of malignant glands in the prostate is losing the outside layer, losing the basilar layer that is surrounding those glands. So at the end of the day, it's going to be your morphologic diagnosis that is going to make the day. All right. So you look here and you will be able actually again to decipher the outer cell layer. Beneath it, deeper to it is going to be the epithelial layer. You look at the epithelial layer and you have to establish, are those epithelial cells that make up the gland benign or malignant? How would you tell that? You would tell that if you look at actually the shape and the size of the nuclei. If all the nuclei look the same, if all of them are actually of small size, and if all of them are bland, small, round, not distinguishing themselves, if you will, then those actually, nuclei are benign. And then you look also at the cytoplasm amount. If the cytoplasm is very ample, is a lot, then the nuclear cytoplasmic ratio, an important ratio that we look at, when we do diagnostics in neoplasia, is going to be low. So all of those features, you're going to combine all these features to reach a diagnosis that what you're looking at is an adenoma rather than an adenocarcinoma. Yes.
How can you differentiate a normal cell and benign?
Right. Well, this is actually not a normal cell because again, you have packed tissue. Usually endometrium should be open. You should see a lot of space between the endometrial glands. The minute that you start, first actually this comes to you from the gynecologist who's telling you, I have seen a mass and this is a biopsy of that mass. So you've already actually, gave you the diagnosis, really, giving you that you need to actually tell me, is this mass benign or malignant? Okay, is this a benign tumor or a malignant tumor? Okay, so, but, if you're asking, between benign tumor and a normal tissue, a normal tissue will not appear like a mass, correct? Correct. So it will not appear like a mass. Two, on histological sections, you're going to see a lot of stroma. So you will see that those endometrial glands are pretty far spread. You will see a lot of space between them. Do you see a lot of space between those? No. So what you're looking at, even if you don't have the input of the gynecologist, you're looking at a mass, probably a polyp. Okay. Here's another example. Your good friend here asked a very important question. So how would you know if you are actually between or in benign or normal tissue versus a a neoplastic tissue, whether benign or malignant, right? Now, this boundary right here is going to really give it to you out. If you look at, normal thyroid, you're going to be seeing that the thyroid follicles are of different sizes, really. Nothing that is going to worry you. There are no signs of invasion. There is no fibroblastic proliferation, that is, preventing the spread of this tumor. There is no vascular invasion. There is no lymphatic invasion. The nuclei look very much, bland, of those tissue right here. But if you look at the size of the follicles, they are of different sizes. Do you agree with that? Large, or actually intermediate, small, and large, right? This is what you see in normal tissue in the thyroid. Again, it's going to be tissue dependent. Okay, so the same rule does not apply to other tissue. Now, if you look here, when you cross this border right here, and you look here, you will start to see that all those follicles look very much the same. So you will start to see what you call monotony. Monotony meaning all of them uniform, monotony, all of them look the same. This is what you see when you have neoplastic proliferation in the thyroid, okay? So that's actually what you got. And you see that those follicles are small. So this is actually one variant of an adenoma of the thyroid known as microfollicular adenoma, because the follicles are small. So you're looking at a thyroid adenoma right here. So how would you tell actually if it's a thyroid adenoma versus a thyroid carcinoma? First, actually, you look at the capsule. And if all the capsules surrounding this tumor look very much the same here, meaning it has not been interrupted by the tumor cells, it has not been invaded by the tumor cells, there is no capsular invasion, then the tumor that you're looking at is a benign tumor, okay? This is one of the things that we do in thyroid pathology, is that you need to take a section of the tumor mass that you have with the adjacent capsule and look for any kind of invasion. If there is invasion, that's going to be follicular carcinoma. If there is no invasion, that's going to be follicular adenoma. Now, within the thyroid itself, also you will look for angiovascular invasion, this stuff that you're going to be seeing later. But here, you look at this. So how is this tumor growing? This tumor is not growing by sending cells into the capsule. Do you agree with that? It is growing actually by expanding, what you call expansile growth pattern, which is what you see in benign tumors, okay? Again, there are the other features that we have already talked about. The cells look very much the same. So there is proliferation, absolutely. You will see it also in the growth. Before, you look at this, there is the gross pathology examination, which is when they send you the thyroid and you cut it and you look at it with your naked eye. Then you take a section of this, tumor mass right here with the adjacent capsule that you are able actually to see with your naked eye, and you send it to pathology to establish the presence of invasion or not. Invasion is not there, then what you are looking at is a benign thyroid adenoma, okay, a follicular adenoma. In this case, as I mentioned to you, microfollicular adenoma. All right, so let's see, what else? Oh, here is actually an example of a benign tumor mass that is arising from surface lining, what you call a polyp. So in a lot of times, actually, it's going to dangle from a stack. Okay, so a stack like this. Here is the polyp. You can see that it looked like a club-shaped tumor arising from that surface. Now, when it lacks a stack, it will actually be, this one will not be here. So the tumor mass is going, the benign tumor mass is going to be connected to the surface directly, what you call sessile polyp. Where do you see it? You see it in a lot of places. The majority of the polyps are going to be seen in the colon, but you may see it, also in the genitourinary tract and in other places in the body as well. All right, so don't confuse polyp with papilloma, okay? Papilloma is, on the other hand, even though the name itself actually may give an indication that it is related to a viral infection. What is the viral infection that is related to papilloma growth? HPV, the human papillomavirus infection, absolutely. Right, but even that, believe it or not, is not all the case. There is known to be that, there are certain papillomas that arise within the genitourinary tract, in the urinary bladder, that you call papilloma, but in reality, they are not actually due to an HPV infection. So, again, medicine and its exceptions, as you know. All right, so papilloma, it's going to actually have a different kind of configuration than the polyp. So in this one will have actually what you call complex branching. Let's see how it will look like. Look at a papilloma that you are finding here arising in the corner of the mouth. You take it out and you cut it, and send it to microscopic examination, and you will be able to see this papillary kind of growth. Each one of those is a papilla, right? And this one actually is due to HPV infection. So the one arising in the corner of the mouth here is due to HPV infection. So you can see that it is different. It's going to be different than what you see with, when you compare it with a polyp. A polyp will be an adenomatous lesion. It will carry what we have seen here, for example, or here. It will have those glands that make up this polyp. Whereas, the papilloma will have these papillary architecture. Each papilla is actually a fibrovascular core that is surrounding with epithelium from all sides and showing features of HPV infection, of a human papilloma viral infection. All right, so the OMA does not always indicate a tumor cell, a tumor or a benign tumor. As I mentioned to you, it may actually indicate malignant tumor. For example, if you take a melanocyte and add to it OMA, you will get one of the most invasive and most devastating, really, tumors that man knew. That is the melanoma. Okay, you add to it actually a lymphocyte, and you call it a lymphoma, the same exact thing. So it is, in this case, it is malignant tumors rather than benign tumors. All right. You may also add it to a word, and you will get a non-neoplastic lesion that may present as a mass. Okay, what you call tumor-like lesions. Example of that, granuloma. If it's with the blood, it's made up of blood. Hematoma, hamartoma. We'll talk about that next lecture, and choristoma. All right, now how would you name the malignant tumor? The same exact thing, but instead actually of OMA, in this case, you will add a carcinoma for the epithelium, and you will add sarcoma for the mesenchymal tissue. So let's start with the epithelium malignant tumors. So if it's arising from a squamous epithelium, you're going to be calling it squamous cell carcinoma. It's arising from a glandular adenocarcinoma, transitional, you call it urothelial or transitional cell carcinoma. Now, that's not really the end of the story, because there are other features the tumor may have. For example, some tumors may be cystic, so you have to add cystic adenocarcinoma. Some of the tumors may be actually very soft, what you call it's as a result of necrosis. So in this case, you will add medullary carcinoma. Some of the tumors, as a result of the invasion of the tumor cells, are going to result in a very powerful fibroblastic proliferation to try to prevent the spread of that tumor. And the result of this kind of process is going to actually give a very solid texture to the tumor mass that you are going to call it Cirrus Adenocarcinoma. Okay, some of the tumors are made up of a lot of actually mucin. If it's made up of, depending again where you are in the body, how much percentage of mucin, you may actually call the tumor you're dealing with mucinous adenocarcinoma. A lot of time, those mucinous adenocarcinoma, especially for example in the ovary, are going to be cystic. So you're going to be calling it mucinous cystic adenocarcinoma, and so on and so forth. So this is epithelial malignant tumors colon. Here's an example of that. So this is actually a tumor arising in the skin. It is simply, digging deep. There is what we call, again, patterns of growth. There are tumors that are known to be ulcerative tumors, meaning they, instead of actually growing outward, they are going to dig deep within the, tissue that they arise or they arose from. Here's an example of that, an ulcerating squamous cell carcinoma. All right. There are other tumors that are going to grow to the outside, what you call exophytic kind of mass, but still arising from actually the drainage site of a patient With osteomyelitis, it is known that one of the complications of the drainage, sinuses of osteomyelitis, a chronic condition, will be the development of squamous cell carcinoma. In this case, it is an exophytic squamous cell carcinoma, okay? Either lesion, and it will look exactly the same. They are keratinizing, they are well differentiated. We talked about this last time. So keratinizing, you look at this and you see the keratin pearl, one of the indications that the tumor is actually behaving exactly or trying to show exactly what a mature squamous tissue, mature keratinizing squamous tissue will show. In this case, the skin. Then you go on higher power and you will be able to discern the intracellular bridges. Both features are going to make it into a well-differentiated squamous cell carcinoma, okay? So adenocarcinoma, if it goes and take a papillary configuration, you're going to be calling it papillary adenocarcinoma. If it's mucinous, as I mentioned to you, we'll call it mucinous. If there is a lot of fibroblastic proliferation, in this case, this orange color, you're going to be called Cirrus Adenocarcinoma. Here's an example of a Cirrus Adenocarcinoma. You can see actually, one of the most important feature of neoplastic process or cancer is going to be invasion. And this invasion usually also called, infiltration. You look at those, edges of those, invading glandular elements, and you will see that it has what you call jagged edges. You know what jagged is? How a knife, doesn't it look like a knife? You know how you put a knife in tissue? It does look very pointy, if you ask me. And surrounding it is this very, very robust proliferative, or proliferation of fibroblastic tissue, trying to prevent the spread of the tumor. That's known in neoplasia as desmoplastic response. Okay, desmoplastic response. So again, look at this. The end result is going to be the combination of the two, the invasive tumor and the attempt by the tissue to prevent its spread is going to give this tumor mass a very solid texture, what is known as a Cirrus adenocarcinoma texture. Here's an example of what you call a lumen within lumen, a cribriform, pattern. There are a lot. This is just, to wet your feet, so to speak, wet your beak, if you will, in the terminology of neoplasia. So in this case, it is an absolutely, a malignant process. It is an adenocarcinoma. How do you know that it is an adenocarcinoma? Because the cell relate to each other in a very, passionate kind of way, if you will. So you will see that they are making lumen, and then within these lumens, you're starting to see extra lumens. So that's a cribriform gastric adenocarcinoma. How would you know, again, like how would you tell if it is benign or malignant? Actually, you look and you will see that there are, some of those tumor cells that are completely dead. When you see that, that's an indication that the tumor that you're dealing with is a high-grade tumor, because the tumor, have spread and have grown so much, it have outstripped its own blood supply. And as a result of that, there will be areas within the tumor mass that are going to suffer, from necrosis. Those areas are necrotic areas where used to be actually tumor mass, tumor cells, if you will. All right, this is one. Two, if you look here, again, you will see the jagged edges, the infiltrative edges that are showing you like a spear actually going through tissue, okay? Here's an example of a papillary thyroid adenocarcinoma. How do you know that actually it is a papillary? You look at, this fibrovascular cores, you follow them. Each one of them is a papilla. How would you define a papilla? It's a fibrovascular core surrounded from all sides by, cells, by epithelial cells. In this case, actually, it is surrounded from all sides by malignant cells. How would you call actually these malignant cells? You look at those nuclei, and you will see that those nuclei have what looks like, some kind of inclusions that make the nuclei empty. This is actually what you see with papillary thyroid adenocarcinoma. It's one of the cartoons that used to happen in the 1950s, long time before you guys were born, where actually the cartoon character has what looks like an empty, an empty eye. The artist who actually who painted that character always made, for an empty eye in when you look at her. So actually they borrowed that name from that cartoon, and they label it on on the papillary thyroid and carcinomas cells that it has orphaned an eye, orphaned orphaned Annie, orphaned Annie eye. So again, this empty kind of appearance of the eyes, and those empty appearances of the eyes here of the nuclei are actually intranuclear inclusions that is going to make the nucleus as if it is empty. Okay. And there are other things that you need to look at. You don't need to worry about it now. It's nuclear grooves, if you will, that is going to be really the one that will seal the deal when it comes to papillary thyroid adenocarcinoma. Again, not for this time, but eventually you will find it. Now, naming the malignant tumors that are arising from the mesenchyme, from the mesenchymal tissue. In this case, you will add the sarcoma to it. Okay. So if it's a bone, again, you will carry, the Latin name osteosarcoma, and so on and so forth. Adipose, liposarcoma, Lyomyosarcoma, Rhabdomyosarcoma, and chondrosarcoma. Here's an example. Usually, sarcomatous tumors are very fleshy. It looks like, it has a lot of flesh. That's exactly what is the case right here, where you see the tumor is very meaty. Here's another tumor that is arising in the uterus of the, and it is actually coming out of the os. It's a form of a rhabdomyosarcoma that is arising in infants. Okay, it's a devastating kind of tumor that arises in infants and usually presents very early in life, as you can see here in this patient. Now, if you look at, again, if you want to take a look at this, true that you see a capsule surrounding this tumor mass, but at the end of the day, there is actually, areas of redness here. What are these areas of redness, in your opinion? These are areas of hemorrhage, which is a feature of malignant neoplasm. Why is that the case? Because we will see actually that as the tumor mass is growing, it is going to actually be making its own blood supply. Now, those new blood vessels that are being made, they are brand new blood vessels, have what you call leaky endothelial fenestrations. So because they are new, they will start to leak out blood, giving rise actually to this hemorrhage that you see here. In addition to this, you see that there are areas that are slightly paler than others. Usually when you see it in a tumor mass, that's a depiction that there is what you call areas of softening or necrosis. Also, another important feature that you see with malignant tumors. Here's an example of a malignant tumor that is arising from the metadiaphyseal region, the most common site for this tumor to arise from. And that's actually is happening. You can see that the growth plate is still here. So it is happening in a young individual. And this is an osteosarcoma, usually the most common site for it to arise in the metadiaphyseal region. You can see that this is a tumor, a malignant tumor mass. Why? Even from the gross, pathology, you can see that it is going into the periosteum, destroying the periosteum, right? Right here, this is what the periosteum used to be. It is going into, and it is cleaving it, cutting it. That's one. Two, it is going also into soft tissue. Here's a piece of muscle. And whoever took this section left it to show you the relationship between the tumor mass and the muscle mass. The tumor mass is going into the muscle mass. So it is going into visceral tissue. So at the end of the day, it is actually a malignant tumor. The size of the tumor itself should really clue you in that it is malignant. And when you take a section of this, you will be able to see that those tumor cells, all of those tumor cells that look spindly here in this section, and they do actually look, pleomorphic. They look dysplastic. We'll talk about that again as we go through this series. But they are still making a very ample amount of this orange red material that looks like cotton. What is this? Do you guys know? So this is an osteosarcoma. It's a malignant tumor of the osteoblast. What does an osteoblast do in normal conditions? What does it create? What does it produce? What does it do? It does what? I'm sorry? Calcification. But how do we get from osteoblast to calcification? What does it produce? Type 1 collagen, right? That's also known as osteoid, right? That becomes mineralized, that will give rise to the, to the mineralized bone, right? Before, I mean, that's, or after it becomes, modeled. Now, actually, so the malignant tumor cells, in this case, the malignant osteoblast, still retain the ability to make the osteoid in this case, which is one of the diagnostic feature of one of the subtype of osteosarcoma, okay? So what you're looking at is an osteosarcoma. And this is the end of this lecture. Let's see. We have a few minutes to kill. Let's see if we can do it. I will need from you, because I missed last week, lecture. I need 1 hour whenever you guys feel that. Well, let's see. Let's see. We can do that here now. See how much we can go. That's it. The will be 2. I'm gonna share this one with them. Would you please share this one with them?